All right, let's get started. In this deep dive, we're going to deconstruct the really complex world of pericardial disease. We'll be focusing specifically on that challenging diagnosis of constrictive pericarditis, exploring how a perfectly healthy pericardium functions and, well, what happens when it transforms into a rigid, rock-like prison around the heart.
So here's our plan for today. We're going to start with the absolute fundamentals, the anatomy and physiology of the pericardium. From there, we'll get into the nitty-gritty of constrictive pathophysiology, then connect that to the classic clinical signs you'd see. And finally, we're going to tackle some really tough differential diagnoses, comparing constriction to restrictive cardiomyopathy and to cardiac tamponade.
All right, first things first. Before we can even begin to understand what goes wrong, we have to get a really solid handle on what's normal. We need to master the pericardium's anatomy and its absolutely crucial roles in how the heart works.
So, you've got two main layers to the pericardium, and they're actually quite different, right down to their embryological roots. You have the parietal pericardium, which is fibrous, and, this is key, it's pain-sensitive. That right there is exactly why acute pericarditis hurts so much. On the flip side, you have the visceral pericardium. It's made of collagen and elastin, and it's pain-insensitive.
Now, it's so tempting to just think of the pericardium as this, passive bag around the heart. But that is not true at all. It has 4 absolutely critical jobs that are central to the heart's mechanics. Let's break each of these down.
Okay, let's walk through this, because this first function, pressure transmission, is just so elegant. When you take a breath in, what happens? Your intrathoracic pressure drops. A healthy, compliant pericardium transmits that drop in pressure directly to the heart chambers. Meanwhile, the superior vena cava, which is outside the thorax, stays at the same pressure. So you've created this pressure gradient that literally pulls blood into the right atrium. It's an incredible mechanism, and it only works if the pericardium is healthy.
And that leads us perfectly into our second function, interventricular dependence. See, it all connects. Because you have that increased blood flow filling the right side of the heart, the septum between the ventricles gets a little push over to the left. This just slightly reduces the left ventricle's output, and that's what causes that totally normal physiologic drop in your systolic blood pressure when you breathe in. When this gets exaggerated, that's what we call pulsus paradoxus.
Okay, function number 3. And this one is all about a simple but absolutely vital formula. The pressure that actually drives the filling of the heart, the transmural filling pressure, is the pressure inside the chamber minus the pressure in the pericardial sac around it. So think about it. If the pressure in that sac goes up for any reason, your filling pressure goes down. It directly messes with the heart's ability to fill, which is the very definition of diastolic dysfunction.
All right, our fourth and final function is a bit more of an advanced concept, but it's really key. It's this idea of systolic concordance and diastolic discordance. What does that mean? Well, as you breathe, the systolic pressures, the squeezing pressures of both ventricles move up and down together. They're concordant. But their diastolic pressures, the filling pressures, actually behave independently. This uncoupling during diastole is a hallmark of a normal, healthy pericardium.
So now that we have a really clear picture of how a healthy pericardium should work, let's flip the coin and look at what happens when it all goes wrong. We're now entering the world of chronic constrictive pericarditis, or CCP. And really, if there's one phrase you take away from this to describe constrictive pericarditis, it's this: a rock-like pericardium. It just perfectly captures the essence of the disease. It's no longer a flexible sac, it's a cage. So what's actually happening to the tissue? Well, it's this nasty process of fibrosis, thickening, adhesions, and sometimes even calcification, turning it literally bone-like. It's usually a symmetrical process. And it's interesting, historically we always link this to tuberculosis, but today, in many parts of the world, the most common cause is actually relapsing, idiopathic, or viral pericarditis. The end result is the same, a rigid sac that puts a hard limit on how much the heart can fill.
Now this is where it gets really fascinating and honestly a little counterintuitive. We call it a severe diastolic dysfunction, right? But here's the paradox. It's not a failure across the board. For the very first third of diastole, filling is not just normal, it's supernormal. It's incredibly rapid. But then, bam, it hits the wall of that rock-like pericardium and comes to an abrupt stop for the rest of diastole. Okay, so we've got the pathophysiology down. How does this rock-like sac and this weird diastolic filling pattern actually show up at the bedside? Let's connect the dots from the pathology to the patient.
Remember that very first function we talked about?
pressure transmission? Well, Kussmaul's sign is what happens when that function completely fails. The rigid pericardium literally can't transmit that negative pressure from the chest into the heart. So when the patient breathes in, the right side can't augment its filling like it should, and all that blood backs up, causing the jugular venous pressure to paradoxically go up instead of down.
And if you look closely at the jugular venous pulse, it practically tells you the whole story. Remember, systole is still working fine, so you get a nice, prominent X descent from atrial relaxation. But the real clue, the money shot really, is that prominent Y descent. That sharp drop directly reflects that supernormal rapid filling in early diastole. It's a highly specific sign for constriction. And then when you get into the cath lab, you see this classic textbook pattern on the pressure curve. It's called the square root sign for a reason. You see a sharp dip, then a rapid rise as that early supernormal filling happens, and then it just flattens out into an abrupt plateau. That plateau is the heart hitting the wall of the constricted pericardium. You know, this reminds me of a classic clinical pearl. A patient comes in, they've got ascites, edema, they're cachectic, and your first thought is, this looks exactly like chronic liver disease. The signs of right heart failure from constriction are a perfect mimic.
So you're heading down the liver disease path, right? It seems so obvious, but then you look at the neck. What does the jugular venous pressure show? In a patient with liver disease, the JVP should be lower normal. But in this patient, it's massively elevated, and that one little finding changes everything. It tells you the problem isn't the liver, the problem is the heart.
All right, now for one of the toughest challenges in all of cardiology, telling the difference between constrictive pericarditis and restrictive cardiomyopathy. They can look so similar, but it's a crucial distinction to make. Let's break it down.
So let's compare them head to head. A few things really stand out for constriction. That prominent Y descent we just talked about, you're only going to see that in constriction. Physically, you might hear a pericardial knock instead of an S3 gallop. And on imaging, you'll actually see a thickened pericardium. That's a dead giveaway. Restriction, on the other hand, is a disease of the heart muscle itself, so the pericardium looks normal, and because the atria are often dysfunctional, you might lose your X descent.
Okay, next up, let's compare constriction with its more acute and frankly more terrifying cousin, cardiac tamponade. One is a chronic disease, the other is a life-threatening emergency.
And wow, these two could not be more different. Tamponade is an acute emergency. Constriction sneaks up on you over years. Hemodynamically, tamponade causes a global failure of diastolic filling the whole time. This means pulsus paradoxus is present in basically all cases, and the Y descent is absent. But the most critical differentiator is Kussmaul's sign. You won't see it in tamponade, and you have to ask why. It's because that bag of fluid, while under high pressure, can still transmit the negative inspiratory pressure, unlike that rigid rock-like shell of constriction.
So, to wrap things up, let's go back to the beginning. Where does this whole constrictive process often start? Well, it frequently begins with a bout of acute pericarditis.
Acute pericarditis is, well, it's dramatic. You've got this sharp, stabbing chest pain that famously gets better when you lean forward. You see these classic global ST elevations all over the ECG, and you might hear that triphasic friction rub. It can even mimic a heart attack. But the real danger, the long-term risk, isn't the acute episode itself. It's the relapses. It's that cycle of inflammation that can, over time, forge that compliance sac into a constrictive prison. And that really makes you think about that delicate line between a temporary inflammation and a permanent, devastating structural disease.